Hi guys, welcome to my YouTube channel. This is Dr. Smita from KMC Manipal and we'll be continuing our topic management of FGR, and we are reading this from the book Williams. This is the 26th edition. I think in the last video there was a lot of static. Now I don't have the time to make it again, but I'll definitely be summarizing the whole FGR topic in a notes format. So I hope that'll be more helpful. Now, if FGR is detected, what you have to do is, there is no treatment for FGR except that you have to monitor and then you have to time the delivery. Also, the main thing that we use for serial evaluation is Doppler velocimeter. You can use umbilical artery Doppler. Umbilical artery Doppler is for monitoring. Decision making, you can use your middle cerebral artery Doppler, ductus venosus Doppler, and the first diagnostic is your uterine artery Doppler. Okay, otherwise supplemented method can be your non-stress test, your biophysical profile, all of these things. Okay, please do not confuse with the modified biophysical profile, which is basically your biophysical profile and biophysical profile. Biophysical profile is when you do detailed ultrasound and you notice the fetus's movements, tone, all of these things. And modified biophysical profile is basically your AFI plus NST. Okay, now what this table is the most important table, and this gives this is not exact, but this gives you a general idea. So when you have all the women starting from first trimester, when they come to you, you do a dating scan and all. So what you have to do is, in women you are suspecting fetal growth restriction. What we do in Kasturba hospital ideally is, when at 20 weeks they come for an anomaly scan, at that time we start screening for these fetal growth restrictions. So you will see in our 20-week scans there is always a uterine artery Doppler mentioned. Okay, so that is our way of screening. But if you are at a setting which is low resource setting, you can do this in suspected fetal growth restriction women. So later on in the next video I'll tell you the major and minor risk factor, but here what as we have read above is women who have obesity, who have hypertension, who have diabetes, who are on any other medication, whose previous baby was SGA, women who smoke. In India that is rare, but women who are continuously smoking, very rigorous physical activities there, and antepartum hemorrhage, things like that. Okay, any infection you're suspecting, torch infections like I had told you, toxoplasma, malaria, all of these things. So what you have to do, you have to do a serial fetal growth assessment, you have to do umbilical artery Doppler, you have AFI assessment, and you have to do fetal surveillance. Now if the umbilical artery Doppler is normal, okay, so then you will do weekly. If estimated fetal weight is 3 to 9 percentile, you will deliver at 38 to 39 weeks. Okay, mode of delivery, according to the woman, you can go for induction of labor also, and you can go for like if there is a specific indication, you can do for cesarean section also. If estimated fetal weight is less than 3 percentile, you have to deliver at 37 weeks. Ideally 37 weeks. Okay, you aim for 37 weeks, you try to make the pregnancy reach 37 weeks. Just because the fetal weight is less than third centile does not necessarily mean that you terminate before term. Now umbilical with absent end diastolic flow. Okay, when that is there, you have to hospitalize the patient. This is what Williams says. You have to give corticosteroids and you have to do NST 1-2 times per day, NST BD. You have to do uterine artery Dopplers 2 to 3 times per week, and growth assessment every 3 weeks. So if this is when if she is already at 33-34 weeks, you can deliver immediately. Okay, but if maybe she is like 30 weeks, so you will try to take the pregnancy to 33-34 weeks. By that time you will give steroids, you will do NST, and you will Doppler do. So by the time she comes 33 weeks, it will be 3 weeks. So that times every week you will do 2 times Dopplers will be done. If umbilical artery Doppler reverse end diastolic flow, you have to deliver at 30 to 32 weeks. Okay, if she's less than 28 week, which is the period of viability for India, then you can go for induction of labor, because in those pregnancies doing a cesarean section, because there is less chance for the survival of the baby, and you have to counsel the patient and patient attendants accordingly. So you try to go, you usually opt for induction of labor. But if this is what we practice at Kasturba Hospital, if she's at 30 to 30 weeks, based on the risk factors and things, you can deliver. But you have to make sure that you give corticosteroids, and if she has contractions, you give tocolysis enough for steroids to act. Tocolysis is no role in prolonging the duration of pregnancy. We usually give it to give enough time for steroids to act. And if maybe she's like 30 weeks and you're trying to reach 32 weeks, usually reverse and diastolic flow we immediately deliver. But in case she's 29 weeks and you want to take up to at least 30 weeks, then you have to do daily Dopplers. Although it's written here umbilical artery Doppler 2 to 3 times per week, it's better to do daily, because you will be checking ductus venosus. Usually ductus venosus forward flow is there, but if you get interrupted flow, you have to do deliver. Okay, now the delivery timing balance the risk of fetal death with the hazards of preterm birth. That is why I'm telling you, if 29 weeks you are getting reversed, but you think okay, no, one more week we can somehow, you want to give steroids, or you like one more week, so daily you will do ductus venosus. There was a GRIT, for the preterm fetus, the only randomized trial of delivery timing is the GOAT trial. In this trial 548 women were involved who were between 24 to 36 weeks, and they were assigned immediate delivery or delayed delivery, okay, until the situation worsened. The primary outcome was perinatal death or disability after reaching age 2 years. Okay, mortality. Now basically you were allowing them either immediate delivery, or you were delaying delivery until the situation worsened, which made you deliver. And you were seeing at 2 years the outcome, the disability, either perinatal death or disability after reaching age 2 years. Now mortality rates, like you can see here, did not differ through 2 years of age. Okay, in women who you were delivering early, or in women you were prolonging by 1 week, the outcomes did not differ. So then it makes sense for at least reverse end diastolic flow to deliver immediately, because the mortality rates are not differing. But in children from 6 to 13 years did not show, moreover 6 to 13 years children do not show clinically significant difference. So this is one trial that you can, if you are counseling the patient, you can say, yeah, this was done and this was a randomized controlled trial. So this is something that we can all keep in mind. Then there was also a DIGITAT, disproportionate intrauterine growth intervention trial at term, which aimed to study delivery timing of growth restricted fetuses who were 36 weeks gestation or older. Okay, there were 320 women enrolled, which were assigned to either labor induction or expectant management. So you were inducing labor as in delivering immediately, or observing. So the neonatal morbidity rates did not differ, okay, but neonatal admission into NICU were lower after 38 weeks gestation. So in women you were trying to prolong, the neonatal admissions were lower. Okay, secondary analysis did not identify a clear subgroup that benefited from labor induction and neurodevelopment behavioral outcomes of age 2. So the decision of immediate delivery versus expectant management is usually in clinical practice based on whether you have given steroids, neuroprophylaxis, whether you have given adequate NICU counseling, and then you can deliver. This, like you see in the two groups, there is not significant difference. What you are using is your umbilical artery Doppler. Okay, now you have to know that abnormality represent negative progression. Okay, initially there is increased impedance to flow in umbilical artery, and which may become absent and then it become reversed. Okay, now stillbirth risk in the setting of absent is 7%, in the setting of reversed is 19%. That is why I'm saying in absent you can still take the delivery up to 33-34 weeks, but in reverse, immediate delivery is, I think, the better option. Now this is what you're seeing. This is your umbilical artery Doppler. See how systolic, and this is diastolic, this is systolic, this is diastolic, systolic, diastolic. Okay, systolic, raise, systolic, diastolic, raise, systolic, diastolic. This is S by D ratio increased. Here absent, and here see, this is reversed, reversed diastolic. Here it's absent. So this is the progression. Now here they have given something which is called a ductus venosus Doppler. Okay, now what this explains your umbilical artery Doppler is there is definitely hypoxia happening, and ductus venosus suggests metabolic acidosis. Okay, now he said कि ductus venosus reflect increased central venous pressure from decreased cardiac compliance and higher right ventricular end diastolic pressure. Like in IVC, if the pressure inside the IVC when we raise JVP is there, or when we are taking central venous pressure, that means the right heart pressure is increasing. Same for fetus. The ductus venosus, if you see the fetal heart circulation, you will notice that from the umbilical vein, the blood goes to ductus venosus, it goes to inferior vena cava, it goes to right heart, it goes to left side of the heart, it goes to aorta, it comes out through the umbilical arteries. So if there is increased central pressure and right heart failure is happening, you will see the ductus venosus pressure will increase. Okay, so this is what it reflects. Now there is a 20% risk of stillbirth in such patients, and it increases to 46% when there is a reversed A wave in the ductus venosus. So this is something very important. CPR ratio is the ratio of MCA-PI, middle cerebral artery pulsatility index, upon umbilical artery pulsatility index. Abnormal is CPR less than 1. Greater risk for early delivery, low birth weight, cesarean delivery, and ICU unit and all. CPR was not predictive of adverse perinatal outcomes. Now, when the patient is near term, I think it is better to do an AFI BP and evaluate whether about the termination of pregnancy, as in when to deliver. Now this is when they are near term. Okay, but what if they are remote from term? What if, okay, baby deferred, if they are like 36 weeks, you can wait till 37-38 weeks for full fetal lung maturation. But what if they are very remote, that is before 34 weeks? So what do you do then? There is no specific treatment ameliorates the condition. There is no specific treatment that you can do. There is no amount of, I know some people start aspirin, but aspirin should be started before 16 weeks. And usually you can do this if you know there are risk factor, the woman had come to you earlier, or if there is a risk factor, you can start aspirin at around 20 to 24 weeks. You can do a uterine artery Doppler if it is high. You can start screening with umbilical artery Doppler at around 30 weeks, or every 2 weekly you can do this. See, nutrient supplementation, plasma volume expansion, oxygen therapy, anti-aspirin, all are ineffective. Even aspirin, according to the 2021 ACOG guideline, is ineffective. I hope you can see this. And also ineffective according to ACOG 2021 guideline. Now next you have to go to intrapartum management. Usually lagging fetal growth, which is obviously, I should just tell you here, FGR is early onset and late onset, and this is demarcated by 32 weeks. Early onset FGR is usually due to placental insufficiency, and it's usually easy to diagnose, bad to manage. Whereas the late onset FGR, it's difficult to diagnose but easier to manage because near term, no? So you can deliver, but here you can't deliver, so the management becomes really bad. also you have to know that when lagging fetal growth is the result of placental insufficiency due to poor maternal perfusion, reduced placental function, fetal condition may be aggravated by labor, and especially in that setting, if oligohydramnios is there, there is likelihood of cord compression during labor. Neonatal hypoxia or meconium aspiration is also greater in fetuses who are early onset FGR. Okay. And they're also susceptible to hypothermia, metabolic derangement like hypoglycemia, polycythemia, hyperviscosity, necrotizing enterocolitis, interventricular hemorrhage, all those things. Now, this outcome wala parts is like what is the outcome we'll just go through is very fast. The mortality rate of SGA units born at 38 weeks was 1% and 0.2% with larger. So you can see for SGO neonates at 38 weeks, the mortality was 1% as compared to large birth weights. Also, in analysis of 3,000 newborns born before 27 weeks, those weighing less than 10% had a four-fold higher risk of neonatal death or neurodevelopment impairment and threefold risk of cerebral palsy as compared with non-SGA neonatal. So you have to see at 27 weeks, if there is an SGA fetus, he's four-fold higher. There are four times more likely to get neonatal death, neurodevelopment impairment, and 3 times more likely to get cerebral palsy as compared to non-SGA, even at less gestational age. Okay. Now, early onset growth restriction is prior to 32 weeks. Okay. And this is usually more severe, and this is associated with placental dysfunction. You have maternal hypertension. The pregnancies with early onset FGR have umbilical artery Doppler abnormalities are more as compared to late onset. Okay. Now there is something called Barker hypothesis. So you should know that adult mortality and morbidity are related to fetal and infant health. When your current health is what has been determined by your health when you were an infant. This is what the hypothesis say. So this means that there is a relationship between the suboptimal fetal nutrition and higher risk of subsequent adult hypertension. So if you were an SGA baby and you have hypertension, diabetes, or even if you don't as compared to babies who were appropriate to gestation age, you're more likely to get these diseases. Okay. Now, the degree to which low birth weight mediates adult disease is controversial. Okay, because weight gain in early life is also very important in this regard. Now, FGR may affect organ development, particularly that of the heart. If there was an MCQ and then FGR affects which organ and all, you have to write heart. Okay. Low birth weight babies have cardiac structural changes. There is dysfunction. Okay. And there is also postnatal structural and functional renal changes can also be there. Hence, later on in their life, they might develop hypertension and other vascular insufficiency diseases. Now, prevention ideally begins before conception. You have to counsel a mother who's planning to conceive. You have to modify to help lower FGR risk. So, smoking, cessation is very critical. Okay. Then anti-malarial prophylaxis is very important. Mild to moderate hypertension does not reduce the incidence of IGS in newborns. If you have current hypertension and you're feeling if you get BP under control so that your baby will not be SGA, this says that there is no such correlation. There is no pharmacological therapy. Study of low dose aspirin therapy has not demonstrated consistent benefit in low risk pregnancy. Although aspirin is prescribed, there's no consistent benefit. One, you can see this 2 large meta-analyses were done over more than 20,000 women did find that low dose aspirin was associated with a significantly lower risk of FGR, whether initiated prior to or after 16. So although there is no consistent, like study after study has not proved this, they have done 2 meta-analyses and found if it started prior to or after 16 weeks of gestation, there is, within like 16 weeks, there is a significantly lower risk of FGR. Okay. Now, they did a Cochrane database analysis, small reduction in the risk of SG neonates if you give aspirin to the mother. So, but also these studies had women at risk of preeclampsia and that's why maybe this was helpful, because aspirin helps in preeclampsia. So in women who have risk factor for preeclampsia, pregnancy induced hypertension, if you start aspirin in them prior to or at around 16 weeks, you can prevent FGR in those fetuses. However, evidence in women without risk factors for preeclampsia is lacking. Hence, according to ACOG 2020-2021 guidelines and Society for Maternal Fetal Medicine 2020 guidelines, aspirin therapy for prevention of FGR is not recommended. Physicians can decide as per their experience whether they want to give or not, but according to the guidelines, it is not recommended. So I hope this was interesting to you, and you were able to read one chapter with me. Next section we can do macrosomia, or if you want you can just go through it. It's quite small. I don't want to do it now. I can do it later. So I hope you had a good read. Thank you so much for coming along with me.